Hello, I'm Tom Hoffman. Welcome to our Ask the Doctor session. This is where we learn things that are not easily found anywhere else in the Waldenstrom arena. We have received more than 200 questions from around the world for this session, which is a new record. The questions were provided in advance by those who registered from the Ed Forum and by Waldenstromers around the world who participate in the IWMF Connect discussion list and on the IWMF Facebook page. Thank you for sending them in. They were all reviewed and chosen, and the chosen questions were the ones that were either asked the most or seemed to be most likely to help the most people. Today, we have a cadre of the brightest doctors in Waldenstrom. I want to thank Drs. Treon, Castillo, and Ansel for taking the time to prepare and deliver presentations throughout the forum and for thoughtfully agreeing to respond to these questions after their presentations. I would like to introduce the doctors. Dr. Stephen Treon is the director of the Bean Center for Waldenstrom's macroglobulinemia research. His lab work discovered the highly prevalent MYD88 and its mutations in Waldenstrom. This discovery enabled the first ever breakthrough designation by the U.S. FDA for acceleration and approval of ibrutinib for the treatment of Waldenstrom. Dr. Treon will be starting a new IWMF-funded research project next month. It will be looking even deeper into the MYD mutation, and part of it is to address the resistance to ibrutinib that many of us develop. Dr. Treon is also on the IWMF board. Dr. Stephen Ansel is an oncologist and researcher at the Mayo Clinic in Rochester, Minnesota. He is focused on understanding the biology of B-cell malignancies and to explore the role of the tumor microenvironment in supporting cancer cell growth and survival. The goal of his program is to translate this knowledge into new treatment approaches for patients. He is currently working on an IWMF-funded research project on myeloid-derived suppressor cells. These are immunosuppressor cells in the bone marrow. He is the chair of the Scientific Advisory Committee of the IWMF. Dr. Jorge Castillo is a researcher and a clinician at Bingham and Women's Hospital in Dana-Farber. He has recently researched and written about the response and survival of outcomes to ibrutinib monotherapy for patients with Waldenstrom on and off trials. We'll talk about that in a minute. He is also on the IWMF Scientific Advisory Committee. He has many Waldenstrom patients who absolutely adore him. Now, I need to give the audience a disclaimer about the doctor's answers. Our expert doctors are here to educate us, but no matter what they say, it cannot be construed as a medical advice for you. Only your doctor who knows you and all of your labs can do that. I will be rotating the questions randomly between the doctors, and the other two can give follow-ups from their perspective if needed. I may not be able to tell when they want to speak in this virtual world, so if one of you want to give a follow-up, just chime in whenever you want. Let's get right into it. I'm going to use my prerogative and add 3 questions that has just come up on our list. They will be first. The first question is, can you please explain why the NCCN group, it determines what drugs are appropriate for us, will not put newer drugs on the approved list as fast as we want them to? Dr. Ansel?
All right, well, thanks so much for having me on. That's a very good question. And the main reason I think there's sometimes a delay in putting new drugs on the list is those are the NCCN guidelines are used multiple ways. One way is to give guidance to doctors treating patients. The other is to give guidance to patients as to what they might expect. And the third way is for companies and insurance companies to know what they need to fund. So the data that goes into an NCCN recommendation really needs to be based on evidence that's been published so that there's an article that can be pointed to. So in general, even though treatments are looking really promising, sometimes there'll be a little bit of a delay before it's actually NCCN approved based on the fact that there isn't actually yet peer-reviewed publications to support its use. But again, a number of us on this committees serve on these panels, so we are strong advocates for as soon as it's appropriate to actually add these drugs, we do so.
Thank you. Dr. Castillo, I noted a recent publication that I mentioned in your introduction about the on and off clinical trial. It seems to give us a good picture of patients after 4 years on ibrutinib. Could you please give us your results and thoughts about it?
Yes, thank you, Tom, and thank you again to the whole IWMF board for inviting me to be part of this event, which is I absolutely adore to participate. So I think the interesting question is sometimes in clinical trials, patients get highly selected. They have to meet specific inclusion criteria, and there have been always a concern that if what we see in clinical trials is actually what we can also see off clinical trials when patients are less selected, they have some other comorbidities, and they might have not been able to qualify for a clinical study. So we looked at our own experience, and we basically separated our patients from the patients who were in the clinical trials for ibrutinib from the Dana-Farber, and the patients that we have been treating outside of a clinical trial. And then we looked at the different aspects of the clinical presentations and the response and the depth of response and the response rates, as well as the duration of the progression-free survival. And so essentially our evaluation showed us that the response rates and the survival rates are very similar between patients who participate in the clinical trials, in whom obviously we have much longer follow-up, because the initial clinical trial by Steven Trion started in 2012. So we do have patients on ibrutinib for 7 or 8 years in a clinical trial. The patients outside of a clinical trial of trials is a little bit shorter follow-up, but so far the curves and the depth of response and the proportions of response seem to follow very closely what we have reported previously. So I think it's a very interesting finding, and that should inform community doctors that treating patients outside of a clinical trial, it would show similar results of what was originally published.
Great, thank you very much. Would you give the patients were on their ibrutinib for 4 years? Could you tell us how they did, how many of them dropped off of the ibrutinib, and what their survival and PFS were?
Yes. So I can go a little deeper into this. I would say that the depth of response was very similar in both groups. The depth of response in our experience is at least 90%, with a deep response, meaning with a major response, at least a partial response, or better, of at least 60%. And the VGPR rates were around 30%. And that's very similar between the two different groups. The median progression-free survival, which is how long it took for half of the group to actually progress on ibrutinib, has not been reached yet. And I think our follow-up median was about 5 to 6 years. So, I think that's essentially our experience with the patients in clinical trials, and that is being mimicked at this time by the patients outside of clinical trials.
Great. Thank you, Dr. Castillo. Dr. Ansel, this is a 2-part question. I'll give you both of them now. There are a lot of itchy people on the talk list who are getting very little relief. Is this a Waldenstrom mast cell problem, and would H1 blockers help them? Secondly, there is a new publication titled Antihistamine Synergistically Induced CLL Death with TK Inhibitors. Should we all be on H1 blockers with ibrutinib?
Yeah, so again, 2 good questions. Certainly, I think one of the challenges are, as many people with Waldenstrom's will know, is that you can get multiple symptoms, some of them which can be associated with Waldenstrom's, but some of them which might not be. So although you might be itchy, I think it's really important to work with your doctor to work out what the cause of that pruritus, that itchiness is. Sometimes there can certainly be maybe mast cell activation, but obviously there can be mast cell diseases, which could be parallel processes that really need to be excluded. So a more comprehensive evaluation, I think, needs to be done. And so rather than just say to people, that's what's going on, I think you need to work with your doctor to say, is that truly what's happening in my circumstance? The other thing is, itchiness can sometimes develop from medications you're taking. So a comprehensive look at what medications you're taking is really important to make sure that we don't miss the fact that maybe sometimes this is associated with something that you're taking that's different to your disease per se. And then I think the final question about should you take an H2 blocker or H1 blocker in combination with a medication like ibrutinib, I would always be very careful recommending doing that until there's actually clinical trials that show that that's beneficial. Because remember, there are side effects that can come from drugs, and fortunately BTK inhibitors are generally very well tolerated. But you could like you potentiate the beneficial effect, you could potentiate the side effect profile. And that's what trials always want to test. They're testing efficacy and safety. And so I think you really need to ensure that it's a clinical trial in Waldenstrom's patients compared to people who didn't get an additional medication that really shows benefit before one jumps in and just does that. I think otherwise you've got a risk of having more side effects than benefit.
That's great. Good answer. Now we can go to the real expected first questions. Next slide. We want to hear some answers from the elephant in the room, the coronavirus. Is Dr. Treon on now? No. Okay. Dr. Ansel, should Rituxan maintenance be stopped during the pandemic?
Yeah, that's a great question. And the bottom line is, it's a challenging answer to give. So why would you stop using rituximab? Well, clearly that's a treatment that depletes B cells. When you deplete B cells, you may diminish the ability of those B cells to become plasma cells and make antibodies. And we know from rituximab therapy over a long time, your immunoglobulin levels can decrease. I think we have to be honest, almost any therapy that decreases B cells will potentially compromise your ability to make antibodies. The thing we don't totally understand is, does that compromise your ability to mount an adequate immune response? And we're learning about coronavirus that both T cells and B cells are important in fighting against the infection. So to answer the question, my view is it all comes down to risks and benefits. If you've had an outstanding response to whatever was done as your initial treatment, and maintenance is really looking at just keeping things good in case you might have a problem down the road, there may be merit in saying, you know what, the risk of having an infection and having an inadequate immune response is not worth the low risk I might have of having my disease come back and give me trouble. On the other hand, if you really are getting rituximab maintenance treatment because your Waldenstrom's is badly behaved and it's really keeping the finger on it to keep it suppressed down, well, clearly the risk that you might have from the Waldenstrom's is greater, and then you may be more willing to tolerate, the risk of getting an infection and having a particular bad reaction if you have an inadequate response. In general, in our practice, we've used a lot less of rituximab maintenance, really to make sure we give people the best response to COVID-19 as possible. However, nothing beats wearing a mask. Nothing beats staying away from sick people. Nothing beats washing your hands. So I think those are all practical things people can do. Dr. Castillo, let me turn it to you. I'm sure you've had exactly the same question. I'd love to hear what you've been doing.
Yes, thank you. Thank you, Steve. I'm happy to just give you a very, very brief. I mean, I agree with pretty much everything that you just said. I think that has been our approach as well. So I think if the patient is in a nice response, at least a partial response or better, then, really there's no reason to continue maintenance if the patient is asymptomatic and all the other numbers will be very, very positive. But however, if somebody who's having some actual organ damage, right? I think that in that situation, keeping rituximab maintenance to try to keep the disease under control, then that's a different story. So I think it should be more of a personalized approach, much more than anything else. But if somebody's in a good response, asymptomatic, good numbers, I think it's very reasonable to forego maintenance rituximab in that setting.
Tom, do you hear me?
Yes, I do. Dr. Treon, should Waldenstromers sign up for COVID vaccine trials? It's a three-part question.
Well, should patients sign up for a vaccine trial? Yes. However, the eligibility criteria almost always exclude patients who have an active malignancy. Now, there are examples of other vaccines which started off in non-cancer patient populations. The shingles virus vaccine is a good start, where again, cancer patients were prevented from going on that or discouraged because it was a live attenuated virus. And then when the recombinant, studies came along with, manufactured protein, it was specifically targeted to also include cancer patients. So I think for the time being, seeing that we still don't have, a way forward that, has been proven for vaccination strategies, it's unlikely that Waldenstrom patients would be eligible.
Okay, the second part of the question is, when there is a vaccine, should Waldenstromers still only take a vaccine that has a dead virus?
Things have changed. It's not just about, vaccines that use dead viruses or recombinant proteins. With the COVID-19 strategy now, actually messenger RNA is being introduced into the patients to code the protein. So this actually would represent, I think, even a safer approach when a vaccination strategy comes out. Look, this is why we do phase 3 trials. We need the larger data sets to be able to make more informed decisions around safety.
Okay, that's great. So the last question on this question is, when there is a vaccine, should the Waldenstromers take it immediately? Wait a while and make sure that it's not hurting people.
Again, the large trials, which are, numbered in the tens of thousands of individuals, are going to give us some guidance. Now, some of that guidance is going to be affected by, what we know could be some of the concerns around cancer patient use. So I think this is one that, we're all learning in real time, and, the efficacy data, the safety data are going to be critical for us to all, make the appropriate decisions going forward, both as clinicians and as individuals. Is it a priority to get vaccinated? Absolutely, absolutely, absolutely. But we need to do this in an informed way.
Great, thank you. Dr. Castillo, how do I, as a patient, know if I'm really immunocompromised? And if I do know that, and how do I know, and how do I know that a COVID vaccine will work on me since I have Waldenstrom's?
Yeah, so that's an important question, and a question that I don't think we have, formal, way to answer. But I'll do my best here. So our immune system protects us from infections in so many different ways. Unfortunately, we have only two ways in which we can actually measure that effect. So we either look at the number of cells that we have, and I'm talking about the white blood cells, and we have different types of white blood cells, neutrophils and lymphocytes, and monocytes, but we also have, and we call that the cellular immunity, and that's a number-based issue. And on the other hand, we have the antibody-based immunity, which is we have the IgG and the IgM and the IgA. Now, during the lectures yesterday, I had some questions about low IgG levels, and I stated that about 3/4 of our population with Waldenstrom's would have low IgG levels. So I think a combination of those can happen in patients with Waldenstrom's. So I think if a patient with Waldenstrom's had normal white blood cells and to some degree a normal or low normal IgG levels, I think those patients are less likely to be immunocompromised as long as they are not actively getting chemotherapy or therapy of any kind. If the patient is actively getting chemotherapy or rituximab or medications like that, they are definitely immunocompromised. So when I move away the patients who are actively on treatment, because we know that those patients are immunocompromised at different levels. I think chemotherapy probably worse than rituximab alone, and that's probably worse than ibrutinib alone. But again, that's an opinion to some degree. So now, if your white blood cells are on the lower side, specifically lymphocytes, and neutrophils because of the disease or so much, then that's a degree of immunocompromise right there. If your IgG levels are low, and again, what low means differ greatly between physicians. For some people, 600 is low. For some people, 400 is low. For some people, 200 is low. Then that will imply also some degree of immunodeficiency. So how immunosuppressed a patient is, it really varies greatly from patient to patient. And that is a discussion that the patient needs to have with their treating physician to understand exactly what the risk is. And I'm talking specifically about patients who are on active treatment, because we talked about the patients on treatment being immunosuppressed already. Now, how do anybody's going to know if they're going to respond to the COVID-19 vaccine? I don't think anybody knows if they're going to respond to the COVID vaccine or not. I've heard a lot about saying, oh, I'm not going to get the COVID. I should not get a vaccine because I'm not going to respond to it. I don't think we know that with 100% certainty. I don't think anybody knows anything with 100% certainty. So my practice, and again, this could not reflect what other people are doing. My practice is there any damage or any threat that we put the patient on by vaccinating the patient? If a vaccine will be a live virus and there's a risk of reactivation, I would say that's a safe issue, and I probably would not recommend that vaccination. But in terms of toxoids or vaccines that are made out of dead viruses or particles of the virus that cannot get reactivated, I think a safety issue there is very minimal, besides the pain of the area of the injection and some, systemic symptoms, constitutional symptoms the patient might have after the injection. Beyond that, I don't think there's any other problems. So a big safety problem there is not. Now, in terms of efficacy, it might not be 100% efficacious, but let's make a case for being 75% efficacious or 50% efficacious or even 25% efficacious. I think it's better to go in with a 25% protection, likelihood of protection, than 0% likelihood. So in my opinion, if a COVID vaccine will be to come up, I will not know if anybody's going to respond to it the way we are talking about right now, but there is a chance they might. And since there's no safety issue, I wouldn't have any major concerns on exposing a patient with Waldenstrom's to a vaccine that, will not carry major safety issues in terms of reactivating a virus in that context. And I would like to hear what my other colleagues would have to say about that.
So, Tom, maybe I just add to what Dr. Castillo is saying. I would totally agree with him. I think we would typically recommend that, provided it's not a risky vaccine, which at this point we really don't know what's going to win, we would certainly recommend getting it. But I think along with that, we'd recommend that all of the family members and friends around the patient get it too, because clearly if you protect the patient by the fact that nobody in their environment gets it, then they're much more protected in that way. So I think there's a lot of unknowns, but certainly if there's a vaccine out there, we would strongly recommend the patient and the patient's family and friends to get it.
Yeah, I just want to add to Steve's point about, the folks around our patients also being vaccinated is very important. So there are a lot of still unknown questions that we have around vaccination strategies for COVID. The vaccines may afford some protection against getting infected. They may ameliorate, the symptoms related to COVID. But it's also unclear if the vaccine might prevent somebody from still being infectious and transmitting the COVID-19 virus. So one has to keep in mind that even in the setting of being vaccinated, we still don't know if we may have, still the ability to transmit the virus to others. So this is where it becomes extremely important for the patient to be vaccinated. Still, while we're in the middle of the pandemic and we have a relatively high national rate of positivity for the virus, that still practicing social distancing will be part of whatever strategy we have going forward.
Great answers. Next question, please. Dr. Treon, I know you have discussed this yesterday a little bit, but has the Brutinib usage in COVID patients found to be used? If so, which patients should receive it? Also, is it being adopted in your facility for non-trauma ICU patients? And do you know of other hospitals that are using it for Waldenström or non-Waldenström?
No, I think that's a good question, Tom. The study that we published earlier this year in April was one that was quite, interesting. It actually showed that patients who were on a BTK inhibitor, in this case, ibrutinib, seem to have a milder course, associated with COVID-19 in the sense that they didn't get the respiratory, symptoms. They didn't require supplemental oxygen. There was one patient who was on low dose ibrutinib, who his physician actually had stopped the therapy, who then became, very hypoxic. He ended up in the hospital, ended up on the ventilator. But when he was put back on, full dose ibrutinib, they got him off the ventilator within a day, and within a day after that, the patient, was dischargeable home off oxygen. That study actually was meant, to based on a lot of basic science and translational science, also that we learned, was meant to really get us to doing clinical trials based on the clinical observations. But it's those trials at the end of the day, Tom, that are going to determine the use of BTK inhibitors. The trials that are currently ongoing, we have two, one with ibrutinib, one with zanubrutinib, are in non-cancer patients. This is because the FDA really wanted to, minimize risk to individuals. And there are other trials too going on right now with acalabrutinib as well, that are, again, non-cancer patients. Dr. Bird is going to be doing a study, and it should be open very soon, using ibrutinib in cancer patients at Ohio State. So now you have trials that are, predominantly focused on cancer patients, but will include cancer patients very shortly. And it's, again, what we learned. They're randomized, double-blind trials. There's a lot of variability in how patients are doing in the hospital, because you've got, now you've got remdesivir, you've got dexamethasone that's being given. These are also affecting the outcome of patients in a positive way. And until we really have, the data from these double-blind trials, we really are in no position to make, broad recommendations about using BTK inhibitors. The only recommendation that I think, can be inferred, and again, you need to talk about this with your doctor, is that it appears that being on the BTK inhibitor does not, jeopardize you if you get COVID-19. We now have seen enough data out there to say that there's no reason to stop the BTK inhibitor. But again, you should make that decision with your own physician.
Great. I agree with that. This next question is to all of you. I guess we can start off with Dr. Castillo. Is anyone on the panel treating with Rituxan biosimilars like Truxima or Shins? If not, why not?
Yeah, that's a great question. So, particularly me, and again, this is going to be a very specific question that I think everybody will have might have a different answer. At Dana-Farber, we are not using biosimilars at this time. I think the decision of using biosimilars is largely based on the institution and what the institution feels, a medication should be part of their inventory or not. So at Dana-Farber, we are not formally using biosimilars at this moment. Now, I am aware of the biosimilar data, and I'm aware that the biosimilar data has been tried in other conditions like diffuse large B-cell lymphoma, which are, much more common lymphomas, including follicular lymphoma as well. But I do not believe there's any study on biosimilars in terms of their safety and efficacy in patients with Waldenstrom's macroglobulinemia. However, we should then, up to some degree, make the assumption that if it's a medication biosimilar for other lymphomas, it could also be similar for patients with Waldenstrom's. But again, I think the usage of it would rather be, fall into the what we call the P&T committee, which is the committee in the pharmacy that makes decisions in terms of what medications they should use. So I think it's an institutional decision much more than an individual physician's decision.
Okay. Answer?
Yeah, so I think Dr. Castillo is right on. Same is true for Mayo. A lot of the decisions around which agent we can use is driven by committees that have more to do with assessing not only the data but also cost structures and contracting and the like. I guess I would make one other point is that we commonly would also, for convenience sake, use rituximab in a subcutaneous fashion, and not all of the biosimilars are approved for that kind of use. And also, it depends on the biosimilar as to exactly which indication they have an approval for. So there's a bunch of factors that go into it. But similar to what I'm hearing Dr. Castillo say, we typically are not using biosimilars in Waldenstrom's patients.
Okay. Dr. Trion, do you have anything to say about that?
I'm not sure I can add much more to these very intelligent answers. I mean, biosimilars are really meant to target cost of drug. At the end of the day, they're not really there to improve on drug function. There are other monoclonal antibodies, including obinutuzumab, that perhaps have enhanced capability to target the tumor. And that's because, you've got, each one of us has a different immune complex that actually binds to the Rituxan antibody. And I have to say and credit the IWMF, because one of the pioneering studies that showed that was actually done in Waldenstrom's patients, and it was done actually at the IWMF workshop in Las Vegas, where patients had actually given their blood, they allowed themselves to be genotyped, and we then were able to fit into those models how well they did with Rituxan. But I think, newer antibodies like obinutuzumab were meant to really overcome that, to be able to bind, to everyone's immune cells, regardless of their underlying, genomics. I think there's a lot more interest in trying to pursue those kind of antibodies. But even though those still target CD20, there could be differences in the way patients react. In fact, with obinutuzumab, you tend to get more individuals who have the early infusion reaction. I think a more important, question, Tom, is why Waldenstrom patients tend to get more allergic to Rituxan than to patients who are treated with other B-cell malignancies. We've been fascinated by this notion that, about 10%, maybe upwards to 15% of all patients become allergic to Rituxan. It's not the first infusion reaction. People tend to get infusion-related side effects. This is actually an allergy that builds up with repeated use of Rituxan. And, we have some notion that if we switch the antibody over to ofatumumab, which is a fully or more fully human, antibody, you can sometimes overcome that. But I think that's where, the greater interest in our field is to better understand why we see these kind of different effects in Waldenstrom patients. And that's why, as Jorge said, we just can't make assumptions about the biosimilars behaving the same as Rituxan without doing a study in Waldenstrom patients. So for the time being, stick to Rituxan, because at least we know and understand, its use in patients with Waldenstrom's macroglobulinemia.
Great. Thank you. Next question. Dr. Ansel, since you just brought up subcutaneous Rituxan, why is subcutaneous Rituxan after one IV Rituxan infusion not the standard of care for the drug? It seems to be used a lot in Europe.
Correct. So, there's been a randomized comparison that actually showed that the efficacy of the two are equivalent. So I do think once you know that you can safely get it, and again, I appreciate Steve Trion's comment about the fact that you can get more reactions and allergy kind of problems over time with rituximab. So that's a caution, but certainly the subcutaneous administration, once you know you're tolerating it, is a legitimate option to consider. This kind of comes down a little bit to people's practices. And it also comes back a little bit to how you get compensated for it. So many times insurance companies may have different views on which one they'll cover better. And it might also be that if your physician's practice doesn't accommodate that, that can impact it as well. We tend to use quite a lot of subcutaneous rituximab in our lymphoma and Waldenstrom's practice in general, mainly from the convenience for patients and for us, to be frank. But it takes a little bit of work to make sure that everyone's on the same page when it comes to getting this paid for. Because the last thing you want is to go ahead and give it, and then find after the fact that the patient's stuck with a big bill.
Okay, thank you. Next question, please. Dr. Castillo, literature now shows many patients on ibrutinib can do just as well on lower doses of the drug. Why not just start treatment with the lower doses?
Yeah, that's a great question. So, so I would say that the quality of the data that is coming out in terms of lower doses of ibrutinib is not the greatest quality. I don't think we're talking about prospective studies, not even comparative studies in this specific context. So, in that specific situation, the three large studies prospective on ibrutinib were studied at 420 milligrams. The comparative study with ibrutinib and rituximab versus placebo used ibrutinib 420 milligrams. That's the Innovate study. And more recent, the Aspen study, in which zanubrutinib 160 BID was compared versus ibrutinib 420 milligrams once a day. So the large majority of the good quality data really showed that ibrutinib is started at least started at 420 milligrams, by mouth once daily. So I do think there is some data coming out, retrospective data coming out, and actually some data from the Dana-Farber in which patients are going down at lower doses might actually do as well as. Having said all that, number one is retrospective, so there's selection bias. Number two, we don't have a long follow-up, so maybe it doesn't change anything at the 2-year level, but what about at the 5-year? We have patients on ibrutinib for 8 years, so it's going to last for 8 years if we go to 280 milligrams. So I don't think we do have any data, prospective data, good quality data to support that we could or should start at a lower dose. So my practice is to start usually at 420 milligrams and decrease the dose if some degree of toxicity occurs. Now, in our experience, the Dana-Farber database, the large majority of people that went down on the dose because of toxicity, and that's the only reason we decreased the dose, actually those patients were in a very good response to begin with. And maybe that's the reason they sustain the response and they don't lose the response later on. So I do believe that either we need longer data, we need better quality data to actually support starting at lower doses at this
time. I just wanted to add to Jorge's comments. When we think about ibrutinib, sometimes we can be a little, narrow-minded in the sense that we think the only thing that's actually attaching itself is BTK in the tumor cells. And that's not really the only thing that it attaches to. We know through our own studies that, hematopoietic cell kinase, HCK, is also a very critical target in Waldenstrom's macroglobulinemia. It's actually turned on by MYD88, and it's actually HCK that's turning on BTK itself. And HCK, as it turns out, is a target of ibrutinib. It's also a target of zanubrutinib. And, the interaction that it has with HCK is a little bit different than BTK, because when ibrutinib comes along and binds to BTK, it forms a covalent bond. Once that bond is formed, it's hard to get ibrutinib off. But with HCK, it's a non-covalent bond. So the concentration of drug becomes very important. And HCK and BTK are not just targets in the tumor cell itself. There's this microenvironment that's composed of mast cells, that's composed of macrophages, and perhaps even other immune cells that are also impacted by the drug. So drug concentration may very well be critical to not only suppressing BTK, but the other, members, other enzymes like HCK, which become more concentration dependent. And shutting down the microenvironment, the mast cells, the macrophages, also very important because this is what's feeding into the tumor's growth and survival. So I would be very, cautious about starting at lower doses because we know that the concentration for HCK inhibition is somewhere around 40 to 50 times higher than it is for BTK. And we also know how critical HCK is because when we actually mutate out BTK in these studies, see a lot of resistance that you can overcome with HCK inhibition. So This is why I think right off the bat, just saying, sure, start low isn't necessarily the right answer for the vast majority of patients. If it's safety and a patient is having side effects, then you can back down. But starting the other way around, I think, doesn't serve patients well, especially when sometimes we have to get a very quick response.
Thank you. Next slide, please. Dr. Treon, could you give us a quick update on CAR T cell therapy for patients who are in relapse? We hear that many mantle cell lymphoma patients are in relapse at DFCL.
Yeah, I think it's very important not to extrapolate the success of CAR T cells and other cancers to Waldenstrom's. By and large, CAR T cell approaches in Waldenstrom's have been minimized because of the, extraordinary efficacy that we've seen with Bruton's tyrosine kinase inhibitors. We now have 4 of them. We have, a lot of success that Jorge's trial has just shown us also with venetoclax. And there are plenty of other good ideas going forward, such as other BCL2 inhibitors, non-covalent BTK inhibitors, as well as CXCR4 inhibitors. This is why the field has largely focused on the development of these drugs compared to CAR T cells. With CAR T cells, the targeting becomes very critical. This is a lymphoplasmacytic lymphoma. So if you're using CD19-directed CAR cells, maybe they'll get the early B cells, but not the plasma cells. There are strategies to get at the plasma cells, but not at the B cells. And there are strategies now to combine, CAR T cell approaches. But I think it's important, for the audience to know that, these approaches by and large are far more tedious to create, CAR T cells than giving a BTK inhibitor. They tend to have a lot more toxicity. And the length of time that we've seen their benefit, is also, for a lot of patients, very limited. In myeloma, it's about a year's time that one can see benefit. It's not to discourage clinical investigation. I think that there will be a population where CAR T cells will have a function, but it's important to put into context how CAR T cells, with their, efficacy and safety concerns, fare to some of the other approaches that are working in Waldenstrom's.
Thank you. Dr. Ansel, I'm sorry. Let me look here. Dr. Ansel, this slide. Zanubrutinib has shown good results for our disease with lower side effects from atrial fibrillation and bleeding. Does it appear that acalabrutinib, will replace ibrutinib soon?
Yeah, so that's an excellent point, and I think and a good comment. I think we've got a randomized study that has shown that the efficacy of zanubrutinib and ibrutinib is very similar, but the side effect profiles differ. And I think, actually, to be honest, much as this question highlights here is being made of the atrial fibrillation and bleeding risks, and I think that does favor some of the other BTK inhibitors over ibrutinib. But I think one has to remember that you always trade one off against the other because those side effect profiles differ. So acalabrutinib, for example, headache is much more of a common issue. Some GI tract abnormalities can be more commonly seen. So if you're prone to headaches, for example, or if you're prone to GI upset, that may actually impact you quite substantially. Zanubrutinib, again, is very favorable when you look at atrial fibrillation and bleeding risk, but it did have more in the way of neutropenia and more people needed growth factor injections. So, for example, if you've had another chemotherapy and your blood counts came in low, that may not necessarily be your choice. So I think when you put that all together, I don't think anything is necessarily going to replace anything else. I always think it's really great when you have effective agents and you can tailor them to pick the right drug for the right patient. Again, I think each of these agents have merits and they're all very effective. And in fact, I think some of them may suit some patients better than others.
Well, I guess that every drug comes with a little poison, even Tylenol.
Yeah, nothing comes for nothing. Unfortunately, as I say, there's always, unfortunately, a little sting in the tail for everything.
Tom, I just want to add to Stephen's beautiful summary. I think we're blessed to have, the other BTK inhibitors. zanubrutinib, acalabrutinib, and now in Japan there's tirabrutinib, which also is showing remarkable activity. But there are going to be, give and takes. The atrial fibrillation concern is real, but most patients who even get atrial fibrillation on ibrutinib still can be maintained on therapy. In fact, very few actually came off in the pivotal trial. And so we can still manage around, that particular toxicity. There is going to be, as we, now adopt these new BTK inhibitors, a greater conscious on our part to perhaps think out, which one might be more appropriate for a particular patient. If you have somebody who's had a history of atrial fibrillation, you might be tempted to try zanubrutinib. If you have somebody who's been previously treated and their blood counts, tend to be low, you might favor ibrutinib because you don't want to see the neutropenia associated with zanubrutinib. There may be, there may be convenience issues. Ibrutinib is given once a day. Zanubrutinib is given twice a day. That also, may need to be factored in some patients. And in some patients who have, let's say, Bing-Neal syndrome, where the disease gets into the brain and need treatment, there's an experience, a fairly large experience, thanks to Hori as well, which shows that the drug can get into the CNS space and make a difference. And so, I think we're very lucky to have these BTK inhibitors. There are going to be people that are also going to have toxicities with ibrutinib that maybe switch over to zanubrutinib may be possible. But I just love the fact that we have now these new drugs. They're all showing tremendous efficacy and sustained responses. And really our efforts at this point in time are about optimizing them, whether we're adding in venetoclax, as Hori is doing, or adding a CXCR4 inhibitor for patients that have the CXCR4 mutation. To me, that's far more interesting, going forward, is to optimize these BTK inhibitors for patients with Waldenstrom's.
Thank you. Thank you. The Dr. Treon, next slide, please. I have no idea why you're getting this question, but apparently you know the answer. We know that dogs, cats, and horses have multiple myeloma. Do animals get Waldenstrom? I've heard stories about dogs and cows getting Waldenstrom. Is it true?
Yes. And in how exactly, what an astute veterinarian would have made the diagnosis of Waldenstrom's in a cow is beyond me. I mean, you have to be really astute to be able to make that, to make that diagnosis. But there was a cow actually that did show very high levels of IgM, and further investigation did show that the cow did have Waldenstrom's. There was also a dog in France that was diagnosed with Waldenstrom's. That dog was treated then with rituximab and actually had a response. And so it shouldn't surprise any of us. I mean, our immune systems are very, redundant and evolutionarily conserved across, many mammals. And so, what I had wanted to do for the animal in France, the dog in France, is to check and see if the dog had a MYD88 mutation. But unfortunately, we were unable to be able to get the specimen at the time to determine that. But I wouldn't be surprised. We know there's all kinds of transgenic animal modeling now that's being done where, mutations can be introduced, and you can see, some of the, stigmata of Waldenstrom's being replicated in these animals.
Tom, just to add to something that Steve said, lymphomas are the second most common cancer in dogs. So again, as he's pointing out, there are similarities between humans and other mammals. However, just like in humans, Waldenstrom's is uncommon. I think in most other mammals, you can safely say it's uncommon. But I think I don't think it's something you're going to catch from your pet. So I think you can feel comfortable about that.
Thank you. Dr. Treon, next question. How does a person get into clinical trials at your or other facilities? And I'd also like to hear from the other two.
Yeah, no, that's a good question. So, the one thing I just want to say is to everyone, who may require therapy, try to participate in a clinical trial if you can. All this progress that we've seen over the last 20 years with all the new drugs that have been introduced for Waldenstrom's patients all occurred because of clinical trials. We tried the hand-me-down approach for a long time, borrowing drugs from other malignancies. Sometimes they worked, sometimes they didn't. The side effect profiles, were very different sometimes. This is why trials in Waldenstrom's are so critical for us to recognize both the activity and safety of a particular drug. So I encourage, everyone, think about it. It's really how we're going to be able to make, continued success and get us to the cure that we all need and want. The way you should think about, participating on a trial is go to clinicaltrials.gov. It's a phenomenal compendium of trials that you can just put in there Waldenstrom's macroglobulinemia, and you're going to be able to see the trials that are open. You'll be able to see some of the eligibility criteria. You should be able to see even the study centers that participate. And I think it's very critical, for folks out there to know that there are many trials right now that are ongoing that really, require patients to participate, especially if we're going to be able to get an answers in a quick period of time.
Thank you. Dr. Ansel?
Yeah, I think Dr. Treon covered this very well. I think at Mayo, we try very much to have a clinical trial that's appropriate for almost every patient, as I'm sure that Dana-Farber does exactly the same. So whether you're a new diagnosis, you've relapsed the first time, you've had multiple relapses, and also depending on what treatments you've had before, we want to have something that is available to you. Because the key with all of the trials is to make sure that we are pushing the envelope forward. As Steve said, we want to make progress. So we're taking what we think is the current best and trying to improve upon it. So we really encourage patients to participate in trials because you're getting the latest and greatest thinking related to your disease at the stage you're at. I don't know, Dr. Castillo's done a lot of trials too, so I want to make sure he chimes in as well.
Yes, thanks, Steve. Yeah, I mean, I think participation in clinical trials is key. And again, that is the only way to make, advances in the field. So, and I think this group of patients is very interested on this. I get, emails from patients very, very often, communication from patients very often interested in clinical trials. So I think it's something that we need to, work together, different institutions with the patients to make sure that the patients understand the value of participating in a clinical trial, which I think is very rewarding, could be very rewarding for them, but also it helps, other patients in the future, benefit from these treatments as well.
Tom, just one more thing to add. With the BTK inhibitors now, with venetoclax, with mavorixafor, in CXCR4 inhibitor mavorixafor in trial, the convenience couldn't be greater. These are oral medications. And so unlike, the trials of the past where patients had to come, and get their infusions at, very regular intervals, now what we're, mostly investigating is drugs that can be administered orally. So it makes the convenience for patients to participate in these trials even better.
That's good to know. Thank you. Dr. Castillo, the next question, please. Is bendamustine Rituxan still a good primary treatment for Waldenstrom? Is it the best regimen for MYD88 wild type? If not, what is? And is 4 courses of BR the proper recommendation instead of 6?
Yes, I mean, bendamustine and rituximab has a very good position in terms of the treatment for patients with Waldenstrom's at the primary level as well as the relapse setting. It obviously all depends on what have you received previously for therapy. I think it's probably a very highly effective therapy. I think the response rates is very well over 90%, at least in our experience. I think the Mayo Clinic also has a similar experience with great major responses, easily into the 60, 70%. and very good, very good responses also in the realm of, 25, 30, 35% as well. So it is a great treatment. I think it's overall very well tolerated, besides some nausea and some constipation and some rash. I mean, overall, and obviously the infusion reactions related to rituximab, there are very, very little long-term issues. The main long-term issue that I think we need to, acknowledge is the risk of myeloid neoplasms that can occur because of an exposure to bendamustine. So, obviously that is, an aspect to have in mind when we, discuss treatment options with patients in terms of what is the right thing to do. But yes, bendamustine and rituximab is a very good primary treatment for Waldenstrom's and for relapse as well. Now, if it is the best regimen for wild type, it's a little less clear to me. I'm a little more biased, thinking that the wild type MYD88 patients, would benefit from chemotherapy much more than what they would benefit from proteasome inhibitors, for example. But I don't think there's any data to suggest that MYD88 wild type patients do not respond to proteasome inhibitors. So I would say bendamustine as well as proteasome inhibitors are really good options for patients with wild type disease. I would say cyclophosphamide as well is a very good option for wild type disease. Now, we do have a number of clinical trials recently published showing that the new BTK inhibitors and even ibrutinib combined with rituximab might have some benefit for patients with wild type MYD88 disease. I talked about the MYD88 testing yesterday, and obviously what some institutions might mean by MYD88 wild type might be different from in other institutions in terms of the quality of the testing that is being used. But I would say, there are multiple treatment options available for MYD88 wild type disease, bendamustine being one of them, but many other options that I think are also very much effective in this specific population, or should be effective in this population. Now, the 4 versus 6 is an issue that we are evaluating retrospectively. And I think there's some data from Europe as well as some data from the United States suggesting retrospectively, and again, there's always an issue with doing retrospective studies, that maybe 4 courses of bendamustine might be a better option than 6. Having said that, a large majority of the good quality prospective studies are still using 6 cycles of bendamustine and rituximab as the standard of care. So again, we need to be very careful about making these decisions. In my practice, which might be different what other people might do, I do 4 cycles of bendamustine, and if the patient is already in a very good response or very close to being in a very good response, I might actually stop right there. But again, that is not what other people do. And I think that discussion needs to be taking place appropriately between the patients and their treating physician.
Tom, just to add to what Dr. Castillo said, just to agree with him entirely, the 4 versus 6 treatments, I think, as he pointed out, all of the data is based on 6 that have been from randomized trials. So one has to be careful, particularly when compared to other standard types of treatment approaches. In our practice, again, the reason that it's got to be a little cautious is the 4 versus 6 is a trade-off of side effects versus benefit. If you've had 4 cycles, as Dr. Castillo was saying, and you've had a really excellent response, the additional benefit from the 2 final cycles might be very modest, and the increased risk of low blood counts and that kind of thing may be not really worth the little bit of benefit you might get. In contrast, if you've had only a modest benefit, the additional 2 treatments might be quite important. So all of that together, I think 4 to 6 is a little bit individualized, and that's why some of the retrospective studies are a little bit more difficult to interpret, because there's patient and doctor factors that kind of creep into those analyses.
Yeah, I just want to add as well that, we do have the concerns around myelodysplasia and secondary cancers that, are genuine with bendamustine. I know there's both data from the Mayo as well as data from our center, alluding to perhaps a 5% risk. So for younger patients, we tend to avoid that risk, which is why, moving away from bendamustine for younger patients, I think is, very, very appropriate. And there are patients who will present with large lymph nodes or big spleen or have disease outside of the bone marrow, where bendamustine-based approach, I think, is because in general, bendamustine tends to do a much better job when you've got big lymph nodes or big spleen that you're concerned about. There is a study, I think it's also worth mentioning, from France, from the Philo group, that showed that the patients who were MYD88 wild type actually did not fare as well with bendamustine as the patients that were MYD88 mutated, regardless of their CXCR4 underlying genomics. They tended to progress earlier. And so I think, as a field, we still need to better understand MYD88 wild type disease. Some of the early genomic studies that were done and published show that many of the mutations that occur, below BTK, which is why, the BTK inhibitors, at least at first glance, haven't shown the activity level as in MYD88 mutated patients. But we still, have to develop better therapeutics for this population. Both the Mayo data as well as the data from Dana-Farber also show that these patients are at a higher risk of transforming to an aggressive lymphoma. And this also, adds to the mortality associated with MYD88 wild type disease. The last point I just want to make, because Hori brought this up, is the efficacy of some of the other BTK inhibitors as reported in MYD88 wild type patients. I still am very concerned about how MYD88 status, is determined in these studies, because if you're not selecting out the tumor cells and not doing PCR, which is the more sensitive technique to determine MYD88 status, you may very well have a lot of those patients with the MYD88 mutation that are responding, but they're being called MYD88 wild type patients. And until we have a better understanding of how the MYD88 status was determined in those particular patients and how involved their bone marrows were, which also affect the readout, I think one needs to practice a little bit of skepticism in terms of the activity of BTK inhibitors in MYD88 wild type patients.
I just wanted to add one other thing to what Steve just said related to the myelodysplasia side of things. I think that's an area that definitely needs more study. And the reason is just it might be different in Waldenstrom's patients, or maybe it's just that our analysis so far is not enough patients, because bendamustine plus rituximab treatment is standardly given for thousands upon thousands of other lymphoma patients. And that myelodysplasia, which originally was felt to be a concern, has not actually borne out to be a very high percentage in other kinds of lymphoma. So there might be a specific effect in Waldenstrom's, but I think at this point that's not as clear for me as it might have been, overall. So I think that's something that we need to study and look at more.
Yeah, I agree with Steve. I think what we're often very surprised by, Steve, and I don't know what your experiences have been at the Mayo, but now the panels that are being used with next generation sequencing aren't just limited to MYD88 or CXCR4. I mean, when we do bone marrow biopsies, they're giving us data on over 500 different genomic genes and genomic variants within those genes, and it has really struck us how often we see myelodysplastic related gene abnormalities even in patients with Waldenstrom's. And so, to your point, there may be actually a higher risk of myelodysplasia only because, patients with Waldenstrom's, we've also seen very similar data in myeloma, may harbor these types of mutations that don't really come to life until you hit them with a certain drug.
Yeah, I think that's a good point. And I think, we're learning that there are these abnormalities in genes that we're still trying to understand the significance of them that are present as you get older in the population in general. So again, as I think when we're looking at what constitutes bone marrow damage, that's an area that's moving at a very rapid pace. So I think all told, as Dr. Treon's pointed out, I think we just need to keep looking and studying this, because obviously it could be a biology problem, it could be a drug problem, it could be other factor problem, it could be pre-existing drug problem. So I think all of those are things that need to be factored in.
Great discussion, great discussion. Dr. Treon, I'm really glad that you brought up younger people because I'm a very young 70. Thank you. The next question goes to Dr. Ansel. Dr. Ansel, at what high IgM level will you start treatment in an asymptomatic patient? It was noted in the last WWM meeting that these patients have lower survival rates and might do better with early treatment.
Yeah, so that's a good question. And as everyone on the panel knows, that's been a point of contention and lots of debates and discussion over a lot of time. I guess I would say clearly the higher your IgM level is, the greater the risk that you're going to have complications and side effects, because there is more protein around to make your blood thick. There's more protein around to stick to stuff, all of which can cause significant issues. The chief challenge, however, is some people get lots of problems at a pretty low level, and some people get only problems at a substantially higher level. So to pick an absolute number, although there have been numbers that have given us some degree of cut point, but per patient, sometimes that's a lot more tricky. So I joke with patients and say, you want to start treatment the day before you get symptoms. Now, that's not easy always to know when that day is, but if you get a feeling of trajectory that's starting to show that the disease is really accelerating, that's a reason to consider initiating treatment. And IgM going up is part of that equation to analyze when things are moving along. So although you can say there are data for certain numbers at which you want to be careful about now initiating treatment, I think this is much more individualized and really is something that each person could talk to their doctor about, because I think, again, we want to start treatment earlier to avoid complications. And a lot of this is because we've got better drugs now with less side effects. In the old days, we had really nasty drugs with bad side effects, and we didn't want to hurt people. So we were a little more reticent. So I think our threshold for initiating treatment is coming down, which is a good thing, and it's improving outcomes. But I think I don't want to make an absolute number, because there may be people under that number who could get hurt if we stick out and hang in there for that number before we say we're going to go ahead. I know, I'd love to hear what Dr. Castillo, what Dr. Treon think, because, I mean, this is a topic we all probably get asked every single time we see patients in clinic.
Yeah, I'm happy to basically add on. So, I mean, at the Dana-Farber, we typically do not use just the isolated IgM value. I think you guys need to mute your. So, typically at Dana-Farber, we don't use just the isolated IgM value to make any decisions in terms of treatment. We need to look at the trend and all that, and how symptomatic the patient is. But if somebody is asymptomatic, usually when it goes over 6,000, we start getting worried. And the reason for that is because a retrospective study from our group showed that a median time from hitting 6,000 into getting to symptomatic hyperviscosity was about 3 months. So in that scenario, that it's a time in which we have the discussion. I don't think it is kind of a black and white type of approach in which everybody over 6,000 needs to be treated. But I think in my mind, that's based on the research that we have done, it's a level in which we start thinking about it. I do not know that truly just super high IgM levels are clearly impactful in terms of the survival of patients with Waldenstrom's, and therefore, I think might have to do with the likelihood of having CXCR4 mutations and things like that. But I'm not completely positive just the sole IgM levels are actually an adverse survival prognostic factor in patients with Waldenstrom's.
Dr. Treon, any answer?
Yeah, just to add to that, if you've done this long enough, there's always one patient that you will always remember that, had a high IgM, that was asymptomatic otherwise, and, they came back to you with, some catastrophic event that happened because of that high IgM and hyperviscosity, which is why, the study that Jorge just spoke about was essential to do, to try to understand better, when that risk becomes too high. And so if you have somebody whose IgM is going up, that may have some early signs of hyperviscosity symptoms, nosebleeds, headaches, blurry vision, that may have, had a retinal eye exam that even showed plumping out of the retinal vessels. This is the kind of patient that you're not going to sit on and just watch numbers. you're going to want to act on this, because the last thing you want to do is have that patient present with blindness because of a retinal bleed, or because they had a stroke. And so, sitting on these things is not a good idea. It is important to get, the right exams and the right follow-up. But I think it is important to recognize that these things have happened, which is why, there is this concern about not sitting on patients that have high IgM levels.
Thank you to Dr. Trion. Dr. Trion, why do some people have extramedullary disease, liver, spleen, lymph nodes, skin, brain? Does having extramedullary disease change your treatment choices?
Yeah, the why still, remains to be determined. We know that patients who have the CXCR4 mutation are less likely to have extramedullary disease, and that has to do with trafficking of the cells. When you have the CXCR4 mutation, the cells tend to home into the bone marrow, and as a result, they go there and they lock in because of various bridging molecules, and tend to stay in the bone marrow. So we tend to see less extramedullary disease in patients who have CXCR4 mutations. At time of presentation, when somebody's diagnosed, it's very rare to have extramedullary disease. It's about 10%, maybe upwards to 20% of patients. But when the patients present later in the course of their disease, when they're relapsed or require additional therapy, it can be as high as 50 to 60% of patients having extramedullary disease. And sometimes you have to custom tailor, around that extramedullary disease. If it's big and bulky, you might want to prioritize a drug like bendamustine, because the proteasome inhibitors are not very effective at extramedullary disease. We do know that ibrutinib is effective with extramedullary disease. We just haven't studied it in patients with big, bulky disease. And so again, bendamustine may be the preferable drug in those particular patients. But for patients who have, enlarged lymph nodes, where, they may not even be symptomatic, from the, enlargement of those lymph nodes, being able to focus on other parameters of the disease for making treatment decisions is more important.
Thank you. Dr. Ansel, we don't see many patients listing kappa and lambda light chain results in their lab anymore. Are they only useful at diagnosis? Should they be followed after diagnosis?
Yeah, so that's a good question. And in general, that's something that's really important to define right at the beginning. It's part of helping make the diagnosis. It's part of defining the monoclonal protein. Many of the patients are actually typically lambda, but it usually then after that is something that changes. That particular protein doesn't change much. You can sometimes get people who get a second monoclonal protein that can be detected. But I think as far as being tracked, the monoclonal protein, once defined, then becomes what is tracked, and the total IgM is another thing that's tracked. So I think it depends on the lab. Our lab tends to report it out every time, but if you don't see it from your local lab, I don't think that's a mistake. It's mainly useful, I think, right at the beginning.
Thank you. Dr. Castillo, could you tell me why I have two paraprotein spikes, IgA and IgM kappas, after 2 years of ibrutinib?
Yeah, so that's an interesting question. I mean, we have looked into our database in terms of trying to see if our patients with IgM paraproteins in Waldenstrom's actually have other paraproteins along the way. Something that we have seen in myeloma as well. We call it this a biclonal disease, and yeah, we have seen that a small proportion. I'm probably talking about in the single digits in terms of on the percentage of patients can have IgM, kappa or lambda, and another M spike. Could be IgG, which is the most common one. It could be IgA, and it could either be kappa or lambda as well. Sometimes it's kappa alone or lambda alone. And we call, that condition a biclonal condition. We don't have any data at this time that having a biclonal, and I actually have a patient with a triclonal, meaning 3 spikes, have any impact in terms of how to treat, when to treat, how the outcomes or the survival of the patients are going to be. So I think it's an interesting finding. We probably need to do a little bit more research on it, but at this time doesn't seem to have any clinical implication.
Thank you, Dr. Castillo. Crazy. Dr. Castillo, what have you learned so far from your ibrutinib venetoclax phase 2 trial? Is the study still open? Who should apply?
Yes. So this study is open. It's a study that is planned to accrue about 50 patients. This is for patients who have been previously untreated, meaning they have never received any treatment previously to this. So in this specific situation, the study, we have accrued about 9-10 patients. We are going to stop at 12 patients, look at safety, and then move forward with the additional 38. I cannot tell you pretty much what we have learned because we have not really analyzed the data in a very formal manner. We are hoping to see that the combination of ibrutinib and venetoclax are going to derive deeper responses that we have seen previously. We're always looking for that, for that complete response and see if we can get this. And obviously how long the response is going to last. But the kicker here is that the combination of these oral agents is going to be truncated at 2 years. So the idea is to provide treatment for a couple of years, stop all therapies, and see if that response can be sustained even off treatment. So there's a number of things that we are going to learn, the safety and the efficacy of the combination, but also if it's possible to provide finite duration therapy with oral agents in patients with Waldenstrom's.
Thank you. Dr. Ansel, if genetic testing was not done with the original bone marrow biopsy, when should the genetic testing be done?
Yeah, so I think, to be honest, it's really important to have this done. The big advantage is that it can be done pretty much all the way along. So if you didn't have this done as the initial evaluation, I never at any point along the way, if a repeat bone marrow is done, I think unless you're in a complete remission where there are almost no cells detectable, if there's a reason to do the bone marrow, I would certainly recommend that it be done. As people have been hearing all the way through this educational forum, is it gives us information about nailing down the diagnosis, but it also gives us information about some of the treatment choices we might make. So I would strongly recommend that it be done subsequently if it hasn't been done at the start.
Dr. Ansel. Dr. Treon, if my Waldenstrom transforms into DLBCL, will I still have Waldenstrom also? Um,
I was unable to hear your question. Can you hear me?
can you hear me now?
Much better. Can you hear me?
If
Can you hear?
Strom transforms into DLBCL, will I still have Waldenstrom?
I'm sorry, you're echoing so badly. I can't hear your question. Can you repeat one more time?
I'm sorry, I don't know what's going on. If a person transforms into DLBCL, will they have Waldenstrom also?
Oh, okay. That I heard. So, in the case of transformation, you will continue to have Waldenstrom. And in fact, what's interesting is we can try therapies like R-CHOP and we can eliminate the aggressive lymphoma, the DLBCL, but the Waldenstrom still stays behind. This is an indolent lymphoma. And so it's important to keep in mind that some of the therapies that we use that actually can hit very hard, rapidly growing tumors like DLBCL will eliminate those, but the Waldenstrom still remains behind. It may remain behind at a much lower level, but it still remains.
Ansel, after, can you hear me okay, Dr. Ansel?
I can, yes.
After successful treatment with bendamustine toxin and relapse years later, should you repeat BR? I know that Dr. Castillo said yesterday that they do not repeat BR ever at his facility.
Yeah, so again, I think there's a lot of individualization for treatment for patients. I think, as you heard from comments from the Ask the Doctor forum now, and you've also heard through the previous presentations, the blessing we have is multiple effective agents. So what you really want to do is to pick the best choice for the patient. So, for example, if you had bendamustine plus rituximab and you had a good benefit, but it's 3.5 years later, and the disease is active again, there are probably other agents that would give you a greater benefit at this point, and it's a better choice at that time to switch to something else to hopefully get a more prolonged benefit with a BTK inhibitor or something else. On the other hand, if you only had 4 doses of bendamustine plus rituximab and it's 8 years later, and you're only now beginning to show some evidence of disease progression, you might consider another 4 doses of bendamustine plus rituximab based on the outstanding benefit you got from the therapy before. So I think agreeing with Dr. Castillo that it's not always the optimal thing to go back to the same treatment just simply because you had some degree of benefit. I think if you had an exceptional benefit, I would certainly still consider that. So I think when all's told, the big advantage is I'm hoping in the future we'll never have to go back to anything because we'll have cured it and we'll just treat it once and it won't come back ever.
Yeah, I agree with Steve, and I want to clarify that I almost never say never. So probably what I said was we try not to go back to it unless there are specific reasons. And I think, yeah, if you have a great response that lasts, more than 5 or 6 years, we can reconsider. And if it was only a limited exposure, we can always reconsider that. You always have to look at things from a personalized manner.
Thank you. Dr. Castillo, in patients who are started on Valtrex and antifungal during treatment, when should it be stopped?
Well, that's a good question. So at this time, the only recommendation of giving patients valacyclovir during treatment is for patients who are being exposed to proteasome inhibitors. And that includes bortezomib, carfilzomib, and ixazomib. And in that scenario, we continue valacyclovir throughout the time in which this patient is exposed to these agents, and for 6 months, beyond the last dose of any of these agents. At this time, I do not believe valacyclovir treatment is recommended if we're using ibrutinib, or if we're using any of the BTK inhibitors or BCL2 inhibitors for that matter, or even chemotherapy. I know that some colleagues of mine like to use antiviral and antibacterial prophylaxis in patients who are getting bendamustine, but that is not a practice that is formally generalized in all practices. So my recommendation is specifically for patients on proteasome inhibitors.
Thank you. The next question is going to be the last question. And so we can move on. So it's going to be with Dr. Ansel. Dr. Ansel, could you please explain hepcidin and iron deficiency resulting in anemia?
Yeah, so many people will know that people that have Waldenstrom's very commonly have anemia. And in the beginning, we kind of just thought it was because the bone marrow was kind of crowded and there were too many cancer cells that were present. But hepcidin is a protein that antagonizes the ability of cells to utilize iron, which is key for making red cells. So that actually ended up being a very important factor and it comes from the cancer cell that's generating that environment. So as we then now with new agents and old agents change the environment and get rid of the activity of the malignant cell, we see a significant improvement in the anemia. And I think the BTK inhibitors have told us that because they really switch off the hepcidin production pretty briskly, and you get a very nice improvement in hemoglobin kind of right away. So I think, we've learned a lot about the fact that it's not just a space issue, but it's actually a production of foreign protein issue as well.
Thank you, Dr. Ansel. Well, sadly, our Ask the Doctor time is now over. I want to thank each of our amazing doctors for taking the time to respond to our questions and for being attentive to each and every detail. These answers are priceless. Let's give them a huge virtual applause from all of us. Also, I want to thank all of you in the audience for sending the questions and viewing the presentations. I hope these answers help you in your Waldenstrom journey. Now we need to go to slide picture number 33, please. I want to say something about our president, Carl Harrington. Carl is a great friend of mine. He has led the IWMF for 8 years, but sadly he will be stepping down from the IWMF presidency at the end of this year. He has accomplished many things for us. During his reign, we have $10 million in Waldenstrom research. Much of this was due to Carl. Many of the drugs that you know and are using now were funded by the IWMF that Carl was the initiation of. He's been instrumental in making the IWMF a truly international foundation. We now have affiliates in 22 countries and Waldenstromers in 80 countries. He pushed to develop our RFP research process, where we have reached out to the best researchers in the world to do our research. This dramatically raised the bar for our projects. You see, Carl always thinks big, and when someone says that he can do something, his retort is, yes, we can. It has always been about us, the patient. He won't even stay in the recommended hotel when we are at research meetings because he thinks they're too expensive. He wants to save that money and put it to research. What a great guy. He received go to picture 2, please. He received the prestigious Being Humanitarian Award at the New York IWWM workshop for all of the things that he has done for us and continues to do this. Picture 3, as you can see, Carl is in love with his family. We really appreciate Ellie, his wife, who has shown and allowed us to share him with her for the last 8 years. Thank you, Ellie. Carl will continue as a president emeritus to help us find the cure. Carl, the IWMF extends its deepest gratitude for your guidance and selfless devotion to improving the quality of life for Waldenstromers around the world. Now, I'm sure everybody wants to know who's going to replace Carl. Well, the IWMF board is finalizing a succession plan that will be announced in November. Stay tuned. I would like now to turn to our expert doctors as they would like to say a few things. Dr. Ansel, would you like to begin?
So I would just like to echo what you said and just thank Carl for an absolutely fantastic contribution to the IWMF. There's so many things that he's participated in, and again, you highlighted multiples of them, Tom, but I've specifically wanted to thank him for his leadership in the research arena, especially for the work that he's done with the roadmap and how he's facilitated not only the funding, but also helped with the process and the advertising, and really just continuing to take the IWMF's contribution to research to the next level. I also really want to thank him for his interactions with industry. He's done a fantastic job with bringing in financial support and really developing those relationships. And as part of the roadmap, developing relationships with the Leukemia Lymphoma Society. So again, I think all told, his contribution to the IWMF is in many areas, but the area I've been particularly blessed by has been his contribution to the research arena and particularly to the roadmap and that process. So just, Carl, thank you so much and wonderfully done. And we're going to just continue to appreciate your input as you move to the past president / emeritus position. But thank you again for all that you've done.
Thank you, Dr. Ansel. Dr. Treon?
Tom, I have to say, when I first heard this rumor of Carl, departing, I wrote to him, and he, cautioned me not to believe everything that, you hear. And it was followed actually by, a footnote that said, I will still be here. I will still be, very much part of the IWMF. And I really believe that to be the case. I have had the privilege to have known all the presidents of the IWMF, going back to Arnie Smokler, to Ben Rude, to Judith May, and then having the opportunity to work with Carl. I think we've been very, very, very blessed to have wonderful leaders, such as the ones I just mentioned from the inception of the IWMF. And Carl has carried that stewardship, forward faithfully. He's worked very hard on behalf of the Waldenstrom community, but he was able to do something that I think is very special, and that is really to globalize the IWMF. During his term, he brought together many different constituencies, but he also helped to create those in various countries. And he saw this over with great, great pride. I think his ability to also relate to people on the important targets and priorities for Waldenstrom have also been very much heard. He brought industry into the picture. He made them aware of the disease. He helped champion for funding as well as clinical trials. And I think that's been very critical in our ability to be able to move forward. But the one thing that I just want to say about Carl that really touched me was the happiness that I saw in him when we had the young investigators come together at the international workshops on Waldenstrom. It was really his want, and what really sparkled, for him was seeing that we were now creating the next generation of investigators to move the torch forward. And Carl, I think that moment when we were, all together with all those young people who had won the Young Investigator Awards, for me is a very special moment because I saw you beam. I saw how happy you were to know that Waldenstrom was in great hands. And I want to thank you for bringing us there. Your leadership has been tremendous. You've been a wonderful friend and a tremendous supporter for the Waldenstrom's cause.
Thank you, Dr. Treon. Let's go to the next slide. Dr. Castillo.
Well, what can I say about Carl that has not already been said? And I think I understand. I mean, the difference between Steve and me is that for me, Carl has been the only president I met, and I find it hard to believe that that who's going to follow this act. I think the next person really has big shoes to fill. It just try to keep up with what Carl has been doing. Now, what I can say about Carl is that probably has not been mentioned before, but I think is very striking to me as a physician who takes care of patients with Waldenstrom's is that he is a patient with Waldenstrom's, and he has been able to basically, put together his role as a patient and his role as the director of one of the largest institutions for Waldenstrom's in the world and put that together. And that feels, you can feel that. You can feel the fact that all the things that he has done in terms of raising all the funds and making all the connections and bringing the IWMF to the next level is specifically looking for the betterment of the treatments and the lives of the patients. And I think that putting that together, not a lot of people can say they did that, And I think Carl is a great example of how the power and the will of one can actually improve the lives of many. And for that, I think is an example that we all should learn from. And I really wish Carl the best of lucks in his future. And I really would like to thank him for his tireless effort on improving the treatment of patients with Waldenstrom's.
Thank you, Dr. Castillo. Wow, what a great guy Carl is. Thanks each of our doctors for those excellent testimonies. And thanks to our amazing doctors for taking time out of their busy schedules to spend with us this afternoon and to give thoughts and informative answers. Next is our closing. We can go to the next slide. Get your pencils out as you may want to write some of the following down. In closing the forum, I want to thank all of the presenters The IWMF Ed Forum committee members, Sue Myers, Luke Kleppinger, Lisa Weiss, Jim Reeves, Peter D., and the IWF staff, Jeremy Decter, Donna Cotello, Michelle Postic, and Sarah McKinney. And also thank the Waldenstromer volunteer Rick Savoy for the many, many hours spent on the event. The forum presentations will be available until 5 p.m. today on this site and for viewing via the IWMF website later. You'll be notified on the talk list and Facebook when this is made available. I think they may also be able to be found on our website in the near future. I hear that we may have raised about $53,000 for the Walk for Waldenstrom today. Kudos to those who worked so hard to prepare the virtual walk, especially Pete Donatus and Jeremy, and to all those who helped and or donated. We are also to be having webinars throughout the year. The next one will be Making Sense of the Science of Waldenstrom by Dr. Zachary Hunter. It will be on September 9th at 1:30 p.m. Eastern Daylight Time. You can register on the IWMF site. The next Ed Forum will be in St. Louis next June, pending the coronavirus issue. We would like to thank our sponsors for bringing you the 2020 virtual forum: Biogene, Selectar Biosciences, Janssen Pharmaceuticals, Treadway Foundation, and XR Pharmaceuticals. Thanks again to everyone. We will see you in St. Louis. The Ed Forum is now over. Be well and be safe.